Witnesses in support, please.
Mr. Chair and members, Sawait Siyum on behalf of Health Access California. We are pleased to sponsor AB 339 by Assemblymember Gordon. AB 339 provides basic consumer protections. Imagine you are someone with multiple sclerosis, rheumatoid arthritis, or HIV/AIDS, and your condition requires a prescription drug that costs $6,000 or more for a single prescription in the first month. How would you pay for that? A recent study found that the average consumer has about $2,300 in their savings or checking account. How do we expect the average constituent to spend literally more than they have in the bank to pay for a single month's prescription? We know what happens when consumers can't afford their prescriptions. There is ample academic literature which suggests what common sense shows us. People skip doses, they cut pills in half, and some people just don't pick up their prescriptions. The opposition talks about the rising cost of prescription drugs. Whose job is it to negotiate with pharmaceutical manufacturers over the cost of prescription drugs? The individual consumer or the health plan and pharmacy benefit manufacturer? AB 339 gets the consumer out of the middle of what one member of this committee called the clash of the titans. We respectfully ask for your support of this bill. Thank you.
Hello, my name is Ann Donnelly. I'm the Healthcare Policy Director with Project Inform. We're an HIV and hepatitis C advocacy and education organization. We support AB 339, and we believe it takes the next critical steps in delivering the promise of healthcare reform, so that's access to quality and affordable healthcare to Californians with HIV, hepatitis C, and other chronic conditions. There are many critical provisions in 339, but I'm just going to address two of them in the interest of time. The first is the prohibition against placing all or most drugs used to treat a specific condition on the specialty tier. It's essential for people living with HIV and hepatitis C. It ends discrimination against people with chronic illness and allows them real choice in their coverage. People with HIV and hepatitis C have to have a range of affordable treatments to put together the most effective treatment regimen. Different drugs work on different viral strains, they have different resistance and side effect profiles, and they're employed in different combinations. One drug on an affordable tier will not provide reasonable access. Capping the cost of an individual drug, as AB 339 does, is the only way to ensure access to essential medications. Most people with HIV and hepatitis C take more than one drug each month. They have many other health care costs. People with HIV and hepatitis C have to be able to adhere to their drugs on a daily basis in order to get the best health outcomes, and adherence is simply not possible when drugs aren't affordable. Ensuring affordable and appropriate treatment for people with HIV and hepatitis C is not only important for individual Californians' health, it's a giant step towards ending these epidemics in California. Effective treatment dramatically decreases new infections. Access to affordable treatment protects not only individuals, but the health of all Californians. We support this measure and ask for your aye vote.
Additional witnesses in support.
Good afternoon. Betsy Imholtz from Consumers Union, the advocacy arm of Consumer Reports. I was part of the work group on specialty drugs that covered California, and learned there that California is truly the Wild West in terms of specialty drugs. We support
Name,
this
organization,
measure.
and position only at this point. Thank you. We had our two substantive witnesses already. Additional witnesses in support, please.
Maxine Mantell on behalf of the National Multiple Sclerosis Society, California Action Network, in strong support.
Elizabeth Landsberg with the Western Center on Law and Poverty, in strong support.
Emily Rush with the California Public Interest Research Group, or CalPIRG, in strong support.
Jasmine Gordon with the California Black Health Network, in support.
David Ford for the Association of Northern California Oncologists, in support.
Nancy Murish with the Congress of California Seniors, in support.
Rebecca Gonzalez, National Association of Social Workers, California Chapter, in support.
Eve Bukowski with the California Healthcare Institute, and as a patient with a huge stack of bills, strongly in support.
Mr. Chair, members of the committee, Stephanie Roberson on behalf of the California Nurses Association, in strong support.
Jimmy Jackson, Biocom, in support.
Kristen Hare with the Arthritis Foundation, in support. Doug Chiapetto, Union of American Physicians and Dentists with AFSCME and strong support.
Terry Calgar-Hill on behalf of the Hemophilia Council of California and strong support.
Patrick Stone, National Psoriasis Foundation, strong support.
Jerry Jeffy, California Chronic Care Coalition, in support.
Bill Remack, California Hepatitis C Task Force, in strong support.
Thank you. Witnesses in opposition, please.
Mr. Chair and members, Nick Luizos on behalf of the California Association of Health Plans in strong opposition to the bill. Just for starters, Mr. Chair and members, it needs to be said that health plan benefit design is not a cost driver in the healthcare system. It is the procurement costs of services and products that are the underlying cost drivers in the healthcare system. This bill, among many other things, places a legislatively mandated and arbitrary price cap on health plan drug benefit design without any consideration of the increase in premiums, any increase in share of cost for other needed services, or how it impacts the actuarial value of health plans offered through the exchange. Now, we are proud to be a part of a coalition that cares about addressing the underlying cost of drugs. Where we diverge is on some of the solutions, in particularly this one. This bill does not only solve the problem of drug pricing, it actually could make the problem worse. Bills like this remove any reason for drug companies to negotiate better prices for their drugs. Health plans need all the tools they have in order to lower prices and costs for enrollees. Members, Covered California is currently working with health plans and consumers on whether the drug benefit design at Covered California can be modified without hurting more people than it helps. Covered California, we believe, is in a better position to assess what the cost impacts are on premiums, cost sharing, and actuarial value. We don't want to hurt more consumers than we help. And we've seen some analysis of previous versions of this bill that show pretty large premium increases. This bill completely prejudges the Covered California process and will likely conflict with whatever rules Covered California releases. I would also add that this bill applies to the large employer group market. We believe that's inappropriate. Large employers negotiate with health plans on the drug benefit designs that they can afford. And the more burdens that we put on large employers, the more attractive it is for them to self-insure. Self-insurance is outside of the scope of state government regulation. And we're not judging those arrangements, just a matter of policy consideration for the legislature. Federal guidance clearly allows plans to place drugs on tiers based on their cost. It's pretty simple. Plans can't cover the Lamborghini at the Honda Civic price. It's just not possible without increasing costs in other areas of the benefit design. Doing this in the wrong way, in our view, is like putting a Band-Aid on a geyser. You're controlling the quote-unquote retail price, and we're not doing anything to address the quote-unquote wholesale price. It's going to cause a lot of negative consequences on affordability in the health care system. So we're strongly opposed to this bill. Thank you.
Mr. Chairman, members, John Caldwell representing the Pharmaceutical Care Management Association. We're the nationwide association representing pharmacy benefit managers. In our meetings with you and your staff on this bill, we have said that we understand what Mr. Gordon and Ms. Capel are trying to do, but this is the wrong way to do it. Although the bill has not yet been analyzed by CHBRP, an analysis of a virtually identical proposal last year was done. AB 1917, as introduced, contained the language in this bill limiting cost sharing to 1/24 of the annual out-of-pocket expense limit. The CHBRP analysis from last year illustrates the underlying problem with this approach. CHBRP found that enrollee out-of-pocket expenses will, under this bill, would decrease by $21 million in 2015. That's good for who Mr. Gordon and Ms. Capel are trying to take care of. The problem is that to reduce those costs by $21 million, CHBRP says employers, taxpayers, and those who buy individual policies will pay $127 million. Private employers, $28 million. CalPERS, $7.5 million more. Enrollees for individually purchased insurance will pay almost $80 million more. And enrollees with group insurance, CalPERS, HMOs, Covered Cal, almost $13 million. Thus, for every dollar that costs are reduced for enrollees, everyone else in the healthcare system will have to pay almost $6 more in the form of higher copays, higher deductibles, higher premiums. And unfortunately, some of the people we're trying to protect, they're also going to be stuck with those higher copays, higher premiums, higher deductibles. And yes, there are limitations to what the GBRP analysis. Our view is that while the numbers may be accurate for 2015, the phenomenal growth in specialty drugs means that all those costs will increase dramatically. According to one of our PCMA member companies, our country faces an unprecedented 63% increase in specialty drug spend between 2014 and 2016. Ultimately, the problem here is the high cost of these specialty drugs. Until we get control of the actual price that is being charged, every solution looks like this, simply shifting costs from one group to the greater population.
Additional witnesses in opposition.
Mr. Chair and members, John Winger on behalf of America's Health Insurance Plans and Express Scripts, also opposed.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies, also opposed.
Michael Corbett on behalf of the CSAC Excess Insurance Authority in opposition.
Mira Morton on behalf of the California Chamber of Commerce, also in opposition.
Dan Chick with HealthNet in opposition.
Tom Bowen on behalf of CVS Health. We're in opposition.
Teresa Stark, Kaiser Permanente. We have an oppose unless amended position to have the bill conform to covered California action. Thank you.
Allison Ramey with Blue Shield of California in opposition.
Jennifer Cashman, pharmacist, also in opposition.
Kristen Ward, pharmacist, also in opposition.
Questions from committee members? Assemblymember Chu.
Thank you. First of all, Mr. Gordon, I very much appreciate your championing of this issue, and I certainly agree that we have to figure out how to make sure that our patients are not left being stranded. And I'm very open to supporting the approach that you're suggesting here. As you know, we have seen skyrocketing specialty drug prices. The Wall Street Journal just this past weekend referred to a company that had purchased another drug company, and we saw the prices for that company go up by 500%. You've heard testimony today about how high-cost specialty drugs in the coming years will increase fourfold, from $90 billion this year being spent to close to $400 billion being spent by the year 2020. I think this approach that you've proposed is very helpful in the short term of making sure that specific certain patients who have to deal with high-cost specialty drugs are being dealt with. But what is your thoughts on whether this will actually tackle long-term high-cost drugs? Is this really going to have an impact in that area?
Yeah, I think as I said at the beginning, some prescription drugs, especially drugs, are very expensive. Candidly, this bill does not address the reason for that. This bill is designed to protect consumers, and so, as you say, in the short term, we get some consumer protection. We leave it to others, and I'm happy to work with them to take a look at what we can do around these high-cost drugs. But at this point, I'm on the short term and in the immediacy looking at consumer protection.
Great, and I want to thank you for your candor with that statement, because I agree with you completely. I think that that in the short term, this is helpful for patients that have ailments that are require very expensive treatments, but in the long term, we're really back where we started, and I'm concerned that we are going to see rising premium rates because we can't tackle the cost of high-cost specialty drugs. So from my perspective, and I just want to say to colleagues, I think we're going to need to have a number of solutions to address this short-term and long-term, and I do hope that we will all be able to work together to make that happen. But that being said, I do plan to support this, and thank you for your work.
Thank you.
Assemblymember Bonilla.
We're talking a lot about the issue of the high cost of drugs, and I think this is, the cost to consumers is really important, especially those who perhaps can't afford it. I want to make sure that it doesn't become something, that we lose the sight of the fact that it costs a lot of money to make these very targeted, and it's actually going to cost more. And we want innovation. I mean, if you look at the work that's being done, they're narrowing down what they can, who they can help, and how they can help them effectively, and that is going to cost a lot of money. So, at some point we're going to have to decide whether we want a cure or not, and then have a realistic cost. My question is that what was raised was the cost shifting. Can you please answer that concern that was raised about cost shifting?
Yeah, the Covered California actually has looked at this issue, and as they did an analysis, they found insignificant increases would occur in premiums in 2016. That was their analysis. So Covered California does not think that this has much of an impact on premiums longer term. There's been some additional analysis that suggests that the impact of this, given the number of patients that we're talking about, the smaller number, is probably de minimis relative to premium increases.
If I might, through the chair, Beth Capel on behalf of Health Access California. In its work, Covered California was looking at the benefit there, which is a fairly low actuarial value. That means the consumer pays a fairly high share. Different plan actuaries had different estimates of the cost over the 5 years. They estimated it varied from 0 to about 0.5% per year, or about 3% cumulatively over between 0 and 3% over 5 years. We did spend a lot of time looking at that because it's a fair concern that we're shifting to other things. They did not find, at least in the near term, any need to increase cost sharing for anything else in order to meet the actuarial value standards that they have to meet. So, thank you.
Assemblymember Chavez.
Member Gordon, I appreciate the bill because I think you've identified in a very important area. But as I look at it and looking at the hearings we've had, and I think we're going to have them here later on, discussion on pharmaceuticals, because of our technology and innovation, medical costs are going up in a lot of different areas. In particular, when you look at the hospital costs, the role of robotics are playing in that, the new research going in for DNA sequencing for different ailments, just the quality of care that we have is going up. And I think, as we discussed in one of the other hearings, the cost of pharmaceuticals has been going up in a proportion to everything else that's going up because the technology is going that way. My concern right now is that we don't really know the full impact of Covered California or how we're going to go forward with this. And so my caution is that we need to see this go through a couple times iterations till we see really what is the cost. Because essentially what we did is we brought a lot of people in who deservingly need the care, but we were assigning the cost to everyone else or to businesses or, just the other day I had a number of union groups in my office, and they were saying their rates are going up in healthcare, and the reason is because they can pay for it. And so smaller businesses can't keep with it. My point is there's a lot of things going on in the healthcare industry, and to do this right now, I think, though we need to look at the cost, I think we need to let the dust settle before we go forward. It's not that I don't recognize this issue, and not that I feel for the people that need this, but I also think we need to ensure that our entire health industry, medical industry, is able to adapt to all the changes we're throwing at them right now. So I won't be supportive of your bill, but I just wanted to make that comment. I recognize on what you're trying to do. Thank you.
Seeing no additional questions from committee members, would you like to close?
Yes, thank you, Mr. Chair, and appreciate the conversation about this issue. There's been some suggestion by the opposition that we ought to wait and see what Covered California does. I would remind you that Covered California affects almost 2 million Californians. This bill affects the other 23 million Californians who are not a part of Covered California. These are Californians with cancer, HIV/AIDS, hepatitis, MS, epilepsy, lupus, and other serious and chronic conditions that need these high-cost specialty drugs. This bill gives them consumer protection relative to the cost of those drugs, and I would respectfully ask for an aye vote.
Thank you, Assemblymember Gordon. We can entertain a motion. We have a motion
Second.
and a second. Madam Secretary, please call the roll. The motion is due pass as amended to appropriations.
Bonta?
Aye.
Bonta, aye. Mainshine? No. Mainshine, no. Bonilla? Aye. Bonilla, aye. Burke? Chavez?
No.
Chavez, no. Chin? I'm sorry, Chu?
Aye.
Chu, aye. Gomez? Gonzalez? Hernandez? Lackey?
No.
Lackey, no. Nazarian? Patterson?
No.
Patterson, no. Ridley Thomas? Rodriguez? Santiago? Stein North? Thurman? Waldron? Wood? It's 3 to 4. He got 7 more.
The current count is 3 to 4. He needs 7 more. We'll leave the roll open. Thank you. It'll be on call. Next, we have our specially set hearing with Assemblymember Grove, AB 1254, item number 23, with my apologies for the delay. Assemblymember Grove.
Thank you, Mr. Chair and members, and thank you, Mr. Chair, specifically for allowing us to go out of order due to accommodate my witnesses from Washington, D.C. or back east and from Southern California. I want to address the members of the body for just a second and tell you that in my presentation you'll hear the word abortion, but please don't close your ears on either side of the issue which you find yourself on, because it really has not a lot to do with that particular issue. It has the context of a violation of separation of powers. So I'm proud here today to present a bill to stop illegal actions and abuse of power by officials within the Department of Managed Health Care. The executive branch is responsible to execute and enforce the laws passed by this legislative body. It does not make laws, nor does it change the laws, or nor is it permitted to selectively enforce the laws that they don't like. But with blatant disregard for the separation of separation of powers, the Department of Managed Health Care officials assume the role of legislators by reinterpreting clearly understood state statute to mean something different than it has meant for the last 40 years. This illegal action in and of itself should be bad enough. But on top of this, the Department of Managed Health Care's officials change in the law in such a way that it has violated the religious liberties of thousands of churches and other California employers at the same time it has violated federal law, and putting in jeopardy tens of millions of dollars in federal health care funds that this state needs to balance its budget. This all started last summer when the California Department of Managed Health Care suddenly changed its policy and threatened to punish any insurance company who sold health care policies without elective abortion coverage. It did this in spite of the fact that nothing in California law nor the Constitution requires private health plans to cover abortions, and despite the fact that the federal Weldon Amendment forbids this type of discrimination. The Department of Managed Health Care Director Michelle Rouillard justified her actions by interpreting a meaning of the application under the 1974 Knox-Keene Act in the California Constitution. Why does Ms. Rouillard think that she has the authority to decide what a 40-year-old law means and changing that law that was the intent of the legislative body at that time? This is a blatant abuse of power that the members of this legislative committee should not tolerate, even if you agree with Ms. Rouillard's policy. This decision also violated the Hyde-Weldon Conscious Protection Amendment, which prohibits states like California from discriminating against health insurance companies offering plans that don't provide abortion coverage. The Department of Managed Health Care has clearly violated this law and now have put into jeopardy over $40 billion in federal funds for programs under the Labor, Health, and Human Services Education Appropriations Act. The Hyde-Weldon Conscious Protection Amendment is based on a well-established and cherished principle that no one should be forced to participate in abortions against their will. This principle established a tentative peace between those who support abortion rights and those who, like myself, consider abortion a great moral evil. The Department of Managed Health Care has completely disrupted this established principle and left every church, every private school, every nonprofit, and every business with no choice but to buy abortion health care coverage for its employees. It's an unconscionable assault on the most fundamental freedoms that we enjoy in this country. Ironically, California exempts certain religious employers from allowing them to not include contraceptive coverage in their health care plans, but the exemption does not extend to abortions. 7 California churches, with the help of Life Legal Defense Foundation and Alliance Defending Freedom, have filed a complaint with the U.S. Department of Health and Human Services offices for civil rights over this illegal discrimination and violation of the law. LLDF and ADF have also filed a complaint on behalf of 7 Loyola Marymount University employees who were forced into a plan covering elective abortion under the DMHC's order. My Bill 1254 will simply restore the status quo that has been in place for 40 years and ensure that the Department of Managed Health Care follows federal law by prohibiting it from discriminating against healthcare companies selling insurance policies without abortion coverage. This bill no way prohibits insurance companies from providing abortion coverage. It just removes the abortion coverage requirement and brings California back in compliance with federal law. Witnesses here to testify are Alliance Defending Freedom Senior Counsel Casey Maddox and Senior Pastor of Calvary Chapel, Chino Hills, Jack Hibbs. You're on.
Mr. Chairman, members of the committee, thank you for this opportunity to speak with you. My name is Casey Maddox. I'm Senior Counsel with Alliance Defending Freedom. On August 22nd, the Department of Managed Health Care ordered all insurance plans offered in the state to cover all legal abortions. The result is that my clients, California churches and other religious employers, were immediately compelled by the state to provide coverage of and pay for elective, even late-term abortions, and individual employees were forced into those plans. This discrimination against health plans that do not cover abortion violates federal law and jeopardizes a significant part of California's federal funding. Assembly Bill 1254 would simply restore the status quo. I will not belabor the point that DMHC's new interpretation of the 4 decades old Knox-Keene Act was not required or even supported by California law, because even if it were true, and DMHC was just now, for the first time in 40 years, in compliance with the law, federal law would still prevail. California accepts federal taxpayer funds under the Labor, Health and Human Services and Education Appropriations Act. For a decade, California has agreed in accepting those funds that it will not discriminate against a health insurance plan because that plan does not cover abortion. Forbidding licensure of these plans, excluding them from the state of California, is discrimination. The DMHC did not discuss the Weldon Amendment in its order and has never explained how its order complies with this federal law. The bill analysis, which you all received, also does not mention the Weldon Amendment. I find that quite surprising and shocking. That the bill analysis you have does not even attempt to explain how this DMHC order complies with the Weldon Amendment. It also does not address either the First Amendment or the California constitutional protections for free exercise of religion, even though DMHC is literally forcing my clients, California churches, to pay for abortions from tithe money. This is illegal and unconscionable. These are churches spending their resources to meet the needs of their communities by feeding the hungry, assisting women in crisis pregnancies, running sports programs for at-risk youth, and even allowing local government to use their buildings for free. They're being repaid by their state government with an illegal and senseless order to pay for abortions for church staff. The HHS Office of Civil Rights is investigating the DMHC. HHS has the authority to terminate tens of billions of dollars in federal taxpayer funds to California because of this violation of federal law. This is not an idle scuffle in the cultural war. Federal taxpayers have made a bargain with California. It is now in violation of that agreement because of the illegal actions of one state agency. This Assembly has previously rejected this extreme position from DMHC by exempting some religious employers from the contraceptive mandate. The Assembly understood that forcing churches to pay for insurance coverage that violates their conscience is wrong. The DMHC has not approached elective abortion with such care and has gone around the legislature in order to enact this new rule. On behalf of my clients, I ask that you support this bill.
Good.
I'd like to speak from the heart to all of you regarding my personal experience as a pastor. I'd first of all like to preface what I'm about to say in light of the fact that on December 24th, 1957, I survived an abortion, so I'm very happy to be in front of you today right now. As a pastor, I represent not only the thousands of pastors in California, but the millions of Christians in this great state regarding our belief and our convictions in the Bible and in God and in natural law. And being a pastor, I am daily called upon to counsel and to give comfort and to guide people through the greatest decisions of their lives. And that guidance and that comfort does not come from any man or myself, but from God and from the Bible. And exercising that freedom that has been afforded to me, both under the Constitution of the United States and by Almighty God, I live my life upon the convictions of my religious commitment to my faith and to my God. And from the beginning of this nation and the Americans' founding, it shows that the pastors of America were the clarion voice and the founding fathers and the decisions that they made. And like them, we must be unwavering pillars called to stand for what is right in the eyes of God. And as a pastor, we are to uphold and honor that which honors God and that which honors life. And so I call upon my brothers in the pulpits of California to stand for life. It is vitally important. And to ask you to side with us, to demand that our convictions and that our obedience to God be recognized, as is our religious and American freedom allows us to be. I demand that those convictions not be disobeyed and not be rejected, but based upon my religious convictions, I must adhere to what I understand the Bible to say. And when I'm asked to fund abortions, to take tithes and offerings from people who come and worship in our church and segregate some of that money out for elective abortions is against our faith, it is against the Bible, and it's against the very God of life. And so we cannot comply with a ruling or an attempt by this state to even go against God, but also against the Supreme Court of the United States that has already ruled regarding the Hobby Lobby case regarding our conscience. And so I'm encouraging you to please consider this. A church has the freedom to answer to God rather than man. And we are concerned citizens. The church that I pastor, over 10,000 people, over 8,600 of them are registered voters. They're engaged. They love their state. But this is a very serious issue that challenges our religious convictions. And I'm being asked by the state that I love, and I was born in San Diego, here my state is asking me to violate my faith and to do something that is against our God and against our Bible. And we cannot do that. Thank you.
Thank you. Further witnesses in support, name and organization and position only, please.
In support, Gina Gleason, Executive Director of Faith and Public Policy.
Karen England, Capital Resource Institute, in support of religious freedom and AB 1254.
Tim Lefevre, Pacific Justice Institute, in support.
Danielle Cullum, City on the Hill, in support.
Kristen Morrow with the California Catholic Conference, in support.
Brian Johnston with the National Right to Life Committee and the California Pro-Life Council. We urge your support.
Jonathan Keller with the California Family Council and California Family Alliance, in strong support.
Wynette Sills, urging a yes vote on this bill. Thank you.
I'm Ralph Merletti, member, St. Rose Parish, South Sacramento, and I strongly support this bill.
Patrick Lee, Roman Catholic priest, strongly in support of the bill.
Donald Chatfield, Fair Oaks, support.
Jean Crucero, Granite Bay, House to Home Showcase, in support.
Steve Patton, Catholic Diocese of Sacramento, urge your support of this bill.
Patricia Del Marmo, I'm the Northern California Area Director for Concerned Women for America. We are the largest women's organization with over 500 members nationally and 20,000 local in California. I strongly support this bill. Thank you.
Jacqueline Aguilar, Fair Oaks, California, in support.
Democrats, dare to oppose Planned Parenthood, at least on this, and vote yes.
Okay. See no other witnesses in support. Witnesses in opposition. Two witnesses up to 3 minutes each.
Good afternoon. My name is Margaret Russell. I'm a professor of constitutional law at Santa Clara University in Santa Clara, California. Thank you for the opportunity to speak in opposition to AB 1254. And in connection with that, I would like to say that my own university, Santa Clara University, was personally very much affected by the events involving the DMHC, and that we are a university community with many people who have strongly held opinions and faith. They have the freedom of speech to express their views, but not the right to violate California law, so that each covered employee is entitled to make her own decision about her pregnancy. Ensuring that health care plans provide coverage for abortion does not require any individual to use that coverage. It simply ensures that women have adequate health insurance. California law does not require employers that object to abortion to purchase a health insurance and policy that covers abortion, nor does it require health insurance plans that object similarly as well. In terms of constitutional law, this bill relies on a faulty interpretation of California constitutional and statutory law. California law states that insurance providers coverage for the full range of reproductive health care services, including abortion. These are basic health services to ensure that every woman with health care coverage can make her own best decision for herself and her family, not in accordance with her boss. Article 1, Section 1 of the California Constitution ensures each woman's privacy right in determining whether or not to carry a pregnancy to term. This long-settled authority is reinforced by California's Reproductive Privacy Act, which provides that a state may not deny or interfere with a woman's right to choose or obtain an abortion prior to the viability of the fetus or when the abortion is necessary to protect the life or health of the woman. This is in the Health and Safety Code. It is the law. The California Supreme Court further held in the Myers case, cited above, that California could not exclude coverage of abortions defined as not medically necessary while subsidizing all prenatal and delivery expenses under the Medi-Cal program. The court held that this would constitute unequal treatment in a woman's individual right to make critical decisions regarding her pregnancy. Under California's Knox-Keene Act, any legal abortion meets the Act's medical necessity criteria because the procedure is a clinically qualifying health care service provided by a physician to treat pregnancy. This is also in the Health and Safety Code. And finally, I would just like to say, in returning to my own employer, a university that was deeply affected, that there are many people who support the DMHC's right to continue to deny, suspend, or revoke the license of health plans if those plans exclude coverage for abortion.
Thank you.
Thank you.
Members, Christina Romero, Planned Parenthood, affiliates of California, in strong opposition of AB 1295. We represent over 115 health centers across the state, serving approximately 1.5 million patients a year. In California, every woman has a constitutional right to decide whether to end a pregnancy. California has had a long history of supporting reproductive health access, including abortion. Some of these laws date back to 1975. Both the California Constitution and the Reproductive Privacy Act require the government to treat abortion and childbirth equally. California laws regulating insurance require that plans not discriminate against abortion by limiting coverage. In August 2012, DMHC sent letters to 7 health plans reiterating California law that says abortion, like prenatal care and delivery, is considered basic health care that must be covered in insurance policies sold to employers. The enforcement letters were sent after the agency learned that an insurance company had sold health coverage policies to 2 religiously affiliated universities that eliminated elective abortion coverage. Regardless of how one personally feels about abortion, I think we can all agree that each woman should have access to safe medical care if and when she needs it. Ensuring coverage for all pregnancy options ensures women's access to quality professional care without delay. AB 1295 aims to undo long-standing California law that protects women's health. The bill is a fundamental attack on a woman's ability to choose. If passed, this bill would further encourage unsafe, do-it-yourself termination of pregnancies. For these reasons, Planned Parenthood asks that you vote no on AB 1295.